This is a CT chest, axial cuts, long window. I will go through image before convey my finding. Okay, I can see left lung, lower zone, some reticular shadowing and airspace shadow, as well as some pleural thickening.
Yeah.
There is no pneumothorax, no pulmonary nodule, lung volume is preserved. I would like to check mediastinal window.
So far, what are your comments on the lung window?
In the lung window, there is some reticulation
Where
and
exactly?
thickening. Uh,
In what part of the lung?
it's mainly basal and peripheral. Okay, mainly the disease in the left lung lower zone.
Okay. So
There
what do
is
you
some
want to do?
reticulation. This is the reticulation is localized. I would like to check mediastinal window if present.
What for?
I would like to check other association like lymph node, if there is masses. Okay, this is mediastinal window for the same patient. Uppercuts. I couldn't see any abnormality in the liver or.
Please go up. Focus on the chest.
Okay. Okay. This is the area of reticulation, which I mentioned before. Heart sides appear normal. There is no enlarged mediastinal or hilar lymph nodes. No mediastinal lesion. Vessels appear normal.
So you've seen the mediastinum. There are no lymph nodes. There
Yes.
is no other significant finding.
So I will go for my review areas. In the chest. There is small hiatus hernia.
Okay.
Mm, Trachea appear normal. No lesion seen.
All right. So
Diaphragm
what
is
is your
normal.
conclusion?
Um, in my routine practice, I would like to check bone window for completion of
There was nothing significant on the bone window. So what do you think this is?
um, uh, the focal area of articulation in the lower lung.
Is it just on the left side?
Yes, in the right side also there is changes, but it's of lesser.
So you say there are reticulations or septal thickening in the bilateral basal regions, more on the left side.
Yes, and
So what?
there
So
is
what
no
do you?
honeycombing. There is no honeycombing.
Okay.
No no bronchiectasis, no dilated esophagus. Uh, the density of the liver appear normal.
Okay.
Uh,
So, so what is your
and,
diagnosis? Is there any differential that you'd like to give? And what will you do next with this patient?
um, the reticulation is bilateral, but I think it's more on the in the left lung basal area.
And is
Uh,
there anything significant in the lung epiphysis or the upper lobes?
okay, I will follow lung ABCs. Mhm. Yes, here I can see.
Are the
Yeah.
epiphyses normal?
No, no, it's not normal. There is some also there is reticulation. There is thickening of interlobular septum, and there is some centrolobular emphysema,
Okay.
and
So,
there is a small
so
and there is a small
any
bulla,
diagnosis that comes to your mind?
affection of the apical zone uh, with this reticulation. The differential include mm, subacute or chronic hypersensitivity pneumonitis. Uh,
What
uh,
will you do next?
for this patient, I will review if there is any old investigation. This patient should be sent to respiratory team for further assessment.
Your diagnosis for this case is hypersensitivity pneumonitis.
For the apical, either hypersensitivity pneumonitis
Or
mm, or sarcoid. However, there is no large lymph
and
node.
in the basis there are
This
interstitial changes, yes?
there is interstitial, but could be just an
So when you see interstitial changes in the lungs, what are the complications that can occur that you need to look for on a scan?
pulmonary hypertension. So I should look for the size of pulmonary artery.
All right, please stop
Mhm.
scrolling.
This is MRI brain, axial cuts, FLAIR. Uh, I will go through image before convey my finding. Sorry, it's jumping. Okay. The most striking abnormality is abnormal high signal in both salami as well as brain, midbrain, aqueductal region. There is no other area of abnormal signal, no ventricular dilatation, no other lesion. I would like to check this area in diffusion weighted. I would like to check other sequence as diffusion weighted image.
Yeah, so any differential that comes to your mind?
Um, Bilateral thalamic involvement, differential include infarction, either venous or arterial, could be encephalitis. Um,
You said you want to look at the diffusion weighted
yes, I would
sequence.
like to check.
Please scroll.
Yes, this is diffusion weighted for the same patient, which shown no significant. Mm, yes, I can see restriction. Yes, now scrolling. Uh, so I can see a restriction, but no low signal in. It's not correspond. There is no corresponding low signal in DWI in ADC. Sorry.
So anything else that you want to see before you come to conclusion?
Yes, both contrast. This post contrast, which showed meningeal enhancement and dural
No,
enhancement
it's
also.
not. It's not really. There is no managerial enhancement.
Okay, and
It's
there
just
is
the
no.
vessels that are
Yeah.
enhanced. Yeah, so there is no enhancement on the in the areas that you previously mentioned. So
Yes.
any differential that comes to your mind?
Uh,
You said it could be infarcts.
yes, and
So then what else could this be?
either infarct, encephalitis, or could be uh, encephalopathy.
Encephalitis, I can take as a differential. Okay.
Okay.
What else?
It could be some encephalopathy.
So what are you going to do next?
I will ask if there is any history of alcohol consumption or hypoglycemia. Okay,
So
so this is based and need further management, need good CSF study and referral for neurology team.
yeah, so there were centrilobular emphysematous changes in the upper lobes. Can you appreciate the cystic spaces?
Yes, yes, there
The
is central
central
lobular
vessels running through
emphysema.
them.
Yes,
Yeah. And then there was septal thickening in the bases, more on the left side. Okay.
yes,
Probably there's some early honeycombing also.
okay,
So this was a case of combined pulmonary fibrosis and emphysema. It is one of the entities of the interstitial lung diseases. What was
yeah,
important in this case was you need to rule out the complications as well. See, it is associated with pulmonary arterial
yes,
hypertension. I did show you the mediastinal window, but you probably missed it, didn't you?
yes,
Can you see pulmonary arterial hypertension? Can you
yes,
see the
it's a bit,
pulmonary trunk dilated? The right
yes,
pulmonary artery and the left is also dilated. Other
yes,
than that, there is higher association with lung cancers too. All right. I'd give you just pass in the knowledge. A borderline fail in the observation since you were not able to pick up most of the findings in the first go. I had to prompt a lot. Uh, Clinical reasoning was okay, and the clinical safety and management, since you were going to refer it to the respiratory physician, that's where the patient should be, but you could probably advise an echo too in this case. So this would be between a borderline fail to just pass for me, okay, in this case. With your next case, I showed you the flare first, okay? There were hyperintense signals in the posterior thalami bilaterally. Then you could appreciate the hyperintense signals along the third ventricle. Then there are hyperintense signals in the tectal plate and in the mammillary bodies. Can you appreciate it?
yes,
So what do you think the diagnosis in this case is? Can you appreciate the signal in the tectal plate, the mammillary bodies too?
yes, yes. Now, now it's clear. Mm.
Yeah. So what do you think the diagnosis in this case is? This is Wernicke's encephalopathy. The
Mhm.
patient was a young female. It is associated with alcoholism, yes, but she was a female and there was an esophageal stricture, okay,
Okay.
because of which she was not able to feed. She was starving, and that caused Wernicke's encephalopathy in this patient. All right. So this would again be a borderline failed case for me because you couldn't reach the diagnosis hypoglycemia. I thought maybe you did get a little bit of about the case, but the areas were not clearly mentioned. There was aqueductal gray matter involved too, and in the posterior aspect of the bones and the medulla oblongata. Can you appreciate it?
Yes, clear now.
These are all the areas which are involved in the Wernicke's encephalopathy, and if acute, it can show diffusion restriction too. There was some hyperintense signal in these areas on diffusion weighted sequence. Can you appreciate?
Yes, clear.
Yeah. So this would be a borderline fail for me. Your communication skills are okay. You need to pace up a bit too. You need to speak faster and speak more fluently and speak more clearly and speak more about the findings. You need to work on your observation skills too. And I think if you do that, you can very easily pass the exam. But for now, you need to work hard. You need to practice, practice, practice. So thank you very much. This was from my side. Is Dr. Omer with us? We'll go to him.
Yes, I am here. Yes, I am here. Yes,
Hmm.
I mean, see, knowledge, radiological knowledge and observation in any case, they are going to, score you 80% of the marks. The main thing is your observation and knowledge. So yes, you were picking findings, but you are very, you need to pace up a bit. And otherwise, similar comments as Dr. Shah have made. So just keep practicing and just do daily speaking practice, which I think you are lacking. So otherwise, you're good to go.
Mm. Thank you.
Okay. Okay.
Thank
So do
you.
we have?
Candidate one, I'll stop my sharing my
Yes.
screen and we'll move on to candidate two with Dr. Umer.
Yes.
Radiograph chest of a skeletally immature patient. I am seeing that the ETT tube is noted uh, with its tip in the trachea, and I can see two tubings which are projecting upon the right aspect of neck and right chest.
Hmm.
Another tubing is noted, which is seen projecting upon the left aspect of chest, left aspect of neck and chest, which is seen adjacent to the right aspect of the margin of superior vena cava. There is multiple other tubings are also noted projecting upon the abdominal cavity. There is inhomogeneous opacification in bilateral lungs, more
Can you
on
name the
the
opacities? Sorry, can you name the tubings which you mentioned on the right side of
I
the
think
chest?
that one of these is the ETT, other is I think that double lumen catheter, and the left-sided tube is I
Which
think.
one is that? Can please take the control and point the double lumen catheter for me, please.
So I am referring that maybe these two linings which are projecting upon the right aspect.
Okay, you think these two are double lumen catheter.
These may these are two tubings. They are not classical of the double lumen
So
catheter.
then what are they classic of?
I think that.
Okay, just leave it. Now
These are
continue
projecting
with the.
upon the I think chest wall.
Okay,
So,
okay, okay.
and there is inhomogeneous granular opacification in both the lungs, more in the right lung uh, lower zone.
Hmm.
Apart from that, there is widening of cardiomediastinal contour, and I am reviewing on the review areas to see that uh, there is the bilateral CP angles are uh, acute, and I do not think that there is no definite pneumothorax, and the uh, there is asymmetric lucency in the left lung lower zone, adjacent to the left CP angle, which
Okay.
I would like to confirm on the corresponding other oblique images or lateral view image if available. Apart from that, there is the regional osseous structures are unremarkable. So considering, I would like to have a correlation with patient's clinical data, any
A
prior
sick patient with the reduced saturation, and
so,
to
so
conclude the case and
So to
come to some.
conclude these findings are, in my opinion, findings are suggestive of acute condition like respiratory distress syndrome. I would like to have correlation with patient's prior imaging, urgently inform the referring physician of my findings, and also have a look or to comment upon the lucency in the left lung lower zone, and uh, have pediatric NICU consultation and
Okay. So you said
follow-up radiographs.
okay. So you said that the osseous structures are fine. Can you review them for me once again, or do you still think they are fine?
So I am looking at the osseous structures on the. So there is a finding that there is an asymmetric linear lucency in the right 10th posterior rib. If you can see my
Okay.
cursor,
Just leave. I
that's
cannot see your cursor, but okay. Other than that, anything else?
apart from that,
Anything else?
there is another finding is that there is the left scapula is rotated, and apart from that, there is asymmetric irregularity in the head of left humerus, and there is asymmetric periosteal thickening along
Okay.
the bilateral visualized diaphysis
Okay.
of humerus.
So.
So in these views and considering, can I have the correlation with patient's history of any prior trauma?
Patient has a history of third-degree burns, and then he was taken to the intensive care unit.
So considering this history and considering this asymmetric periosteal reaction,
Mhm.
and the subtle asymmetric lucency in the right and posterior rib, and apart from that, another lucency is noted in the proximal metadiaphysis of left humerus. One of my differentials will also include the possibility of non-accidental injury.
Okay, other than non, give me the differentials for these
Or
periosteal thickening.
apart from non-accidental injury, these can also appear in if the patient in underlying metabolic conditions, uh,
Like
and like mitochondrial disorders, and
which can you name any disorder?
I think uh,
Okay, good. Okay,
and
we'll move to next case now. Okay.
so I am presented with axial post-contrast images of CT abdomen and pelvis. These are performed at the level of the upper cut is at the level of upper pole of left kidneys. I am looking at the stack of images before giving my findings. So what I note is that there is an irregularly marginated asymmetric soft tissue density. This is in the left para-aortic location. In my routine practice, I would measure its AP and TR in short axis, and this is likely a large left para-aortic retroperitoneal nodal lesion, which is causing compression upon the left ureter, resulting in left moderate hydronephroureter. This nodal lesion is causing compression with displacement of adjacent bowel loops. And I can also see that there is compression upon the IVC. I am looking at the adjacent relations with the vessels. So at this is causing displacement of left renal vein without invasion.
Mm.
Another important finding to note is that there is significant asymmetric soft tissue edema, and the left in the last cut, provided cut, I can see that there is the left testis is visualized on the provide in the left sectoral sac with asymmetric soft tissue thickening and irregularity, and
Okay, so give
the
me the differentials and what will you do
so,
next?
so considering these findings, I would, in my routine practice, I would have a review of the bone window images. So, considering these findings, I will have correlation with patient's history of prior trauma, prior imaging, which you mentioned that the patient had an ultrasound. Maybe this was an ultrasound of scrotum, which detected any testicular malignancy leading to retroperitoneal node, resulting in left moderate hydronephroureter. I would urgently inform the referring physician of my findings. I would review
Mm.
my prior imaging, if any, of the patient. I would also, if the scan had another images of, I would like to have a review of the CT, post-contrast CT chest and upper abdominal images
Mhm.
for to rule out pulmonary metastasis. And one important finding is that I would, considering the presence of moderate hydronephrosis, I would urgently inform the IR team regarding the PCN placement. And I would
Mm.
also like to have a look on the bone window images. So I am
Mm.
presented with the ultrasound of the left testes. This is a transverse view in mid portion, which shows an asymmetric isocheic lesion in the left testes. In my routine practice, I would also have a Doppler vascularity of the lesion noted, and this lesion shows patchy internal vascularity. I would also have the look on the, considering that there was on the provided images, I didn't see
Mm.
the right testis in the right scrotal sac. So I would have a review of the right testis also.
Right testis is normal. So
So,
conclude the case for me.
so conclude findings are suggestive of left testicular malignancy with retroperitoneal nodal mass, and
Mm.
considering these were one of my differentials will be considering the most common testicular malignancy with retroperitoneal nodal mass is seminoma. I would
Mm.
inform the referring physician of my findings, have CT chest and entire images of abdomen pelvis,
Okay,
inform
okay,
the
okay, okay. Fine,
PCN
fine, fine,
and
fine, fine,
urology
fine.
MDT discussion.
Okay. Okay, good. You did very good on this case. So this was again a case of testicular lesion, likely germ cell tumor with a nodal metastatic deposits. You correctly identified. I showed this case just to, to know the importance of the last cut. You stopped here, and I think you were going to make the mistake, but you did very well that you scrolled till the last image, and then you identified this lesion, and then so you also come to the conclusion of this lesion. So that was very good. And again, it was compressing the left ureter, which you correctly identified that you will urgently inform for PCNL. So these things were you did very good. Okay, so what is this? Have you heard of ECMO cannula? What is
Yes, I've
ECMO?
tried.
Extracorporeal membrane oxygenation. Have you heard of it?
Yes, sir. Yes.
Have you seen it?
No, sir.
So this is the ECMO cannula basically. So where is this tubing? This is in the right common carotid artery, and this is in the superior vena cava. Okay, so these are basically these are ECMO cannula. Okay,
Okay, sir.
arterial and venous. And why it is done? Why this cannulation is done? As its name suggests, why this cannulation is done?
I think in respiratory distress syndrome, sir, to oxygenation for.
Yes, yes. There is because there is acute. I mentioned you that the patient has history of third degree burns. So basically, patient is in ARDS. Due to ARDS, we have cannulated it, and so there is a lung pathology, and due to this lung pathology, can we explain these periosteal reaction?
Yes.
This is hypertrophic osteoarthropathy. So what are the
Uh,
causes of hypertrophic osteoarthropathy? Different causes.
Sir, one of these is actually more in the adult cases like lung malignancy
Yes,
and
lung malignancy. Other than that,
COPD, chronic pulmonary
very good
conditions.
COPD. Yes,
Uh,
pulmonary conditions, benign and malignant. So
yeah.
please open the Chapman and learn all the causes, all the possible causes of hypertrophic osteoarthropathy. Okay,
Okay.
so basically the underlying cause is these lung disease. And what is the lung process? It is ARDS. Okay, so
Okay.
basically the patient is in ARDS. ARDS has ultimately led to decreased oxygenation, due to which this ECMO cannula is inserted, and has resulted in this periosteal reaction.
Okay.
Okay, and this is central line. I don't think so. You mentioned this. Okay, this is NG tube. And this is ETT. You mentioned the ETT, but you didn't mention these tubes. So please, these lines and tubes are very, very important for exam. These are very important for your short cases. Very important for your short cases. In the short cases, we are going to show you few displays line, few displays NG tubes, few displays ETT tubes. Okay, so please do have a look at them, all of them, and do identify the important lines like these, like that I have shown you. Okay, so I'm sorry, you were borderline fail in this case, but you correctly identified the lung pathology, but you failed to to identify these tubings, and then you to summarize the overall case. So
Okay.
that was from my side, and Dr. Shah has to add anything.
Thank you, Dr. Mel. Brilliant two cases. Uh, the candidate is good. With the second case, he was too good. He was brilliant. He looked at all the things. He was speaking very fluently, and he was able to tell each and everything. So well done on the second case. With the first case, see, for FRCR, what I know is that the lines and tubes are extremely important. You cannot go into your exam without learning about all the lines and tubes. If I was examiner here, and if a candidate would have identified, so ECMO has complications too, you should know about all those complications as well. Uh, I think that you were good with the description. You were able to, other than that tube error, you were able to pick up on most of the findings. With some prompting, you were able to identify the periosteal reaction. So it wasn't that bad, but tubing is a complete no-no. You miss any line or tube, it's not going to leave a good impression in the exam. But you are a good candidate. Just learn about the tubes and lines and practice as much as possible. It was a clear pass from my side in the second case. With the first case, again, a borderline fail. All right.
Okay, sir. Thank you.
Yeah. All the very best. Please.
Thank you. I am scrolling T2 axial images of pelvis. Here I can see loculated fluid intensity lesion in the pelvis. As there is uterus is not visualized, so and there are post-surgical changes in the interior lower abdominal wall, so there is uh, post-surgical changes of hysterectomy, and there are multiloculated cystic areas in both the hemipelvises. I want to see the sagittal T2 and star images.
Click on it once and scroll.
T2 sagittal shows multiple loculations within the fluid, and cystic and areas in the hemipelvis, and likely in the left ovary there are multiple hyperintense areas with internal fluid levels. I want to see the next T1 and T1 fat set images to rule out hemorrhage or fatty lesion.
Okay, please stop scrolling.
Uh,
Just stop scrolling for a minute.
okay.
I have T2 fat side sequence, all right?
Right.
Please scroll.
So on star images, the again lesions are bright, so no fat containing component is appreciated. Further, I will
And you
check
want to see
for
T1.
diffuse.
Okay.
Yes, yes. Here it is T1 hyperintense focus and another on the left side.
What is
So
your
as
diagnosis?
s- um, sir, I am thinking it is endometriomas in bilateral ovaries with fluid uh, in the pelvis, that is post-surgical.
Please stop scrolling. Is the cyst in the middle a part of
Yeah.
the whole process?
Yes, these laterally placed loculated fluid levels containing lesions are endometriotic lesions, hemorrhagic endometriotic lesions, and in the center there is multiloculated fluid intensity lesion, likely post-surgical fluid. Uh, yes, this can be infected fluid, but there is no rim enhancement uh,
Please
in
click on
the.
it once and scroll. Click on it and scroll.
Yeah, yes, yes. So these ovarian lesions show a normal enhancement. However, no discrete solid lesion is appreciated. These areas, I think, are normal ovarian tissue. However, further, I want to confirm correlate with the CA1 to 5. Uh, whether it is uh, raised or not. Otherwise, pelvic bowel loops are normal. Uh, so, in conclusion, uh, there are post-surgical changes of hysterectomy, and their bilateral ovarian or and axial pelvic lesions with internal fluid levels and hemorrhagic content, or likely endometriotic uh, lesions and post-surgical fluid collection in the pelvis. Further, I will
But
discuss it with the gynecologist and
is there
to
any
discuss in
name given to the cystic? Is there any name given to the cystic structure in the middle?
post-surgical fluid uh, can be
What
infective, abscess
you want to
formation.
send this patient to the gynecology department next for further management. Your conclusion is bilateral
Yes,
endometrial endometriomas
uh,
with the cystic
aortic.
collection and
Yes,
with the
yes,
cystic collection. All right.
yes, yes. Frontal chest radiograph, uh, as both the humeral, proximal humeri are not covered in this image. Even then, I can see this as a adult patient. Uh, there is a significant widening of the mediastinum. I can't see any pleural effusion or pneumothorax. Cardiac size is within normal limits. Uh, no free air is appreciated below the diaphragm, and uh, to me, bones are normal. I can't see any surgical changes in the uh, axilla. So the only striking abnormality I can find up till now is uh, widened mediastinum. I am looking
Do you
for
think
any
the left
small
left
pneumothorax.
is the left costophrenic angle clear?
Uh, yes, there is no large pleural effusion, uh, but there can be a bit hazy, but no large pleural effusion.
Okay, so
Uh, as a mediastinum is widened, I will go with the city thorax
with the widened
with
mediastinum, what
contrast.
do you think? What are differentials?
Uh, any cause may be interior mediastinal mass lesions or vascular lesions, including aneurysms and nodes, nodal
Could
lesions,
this
and
be a
in the
posterior mediastinal mass?
uh, yes, it can be, but as here I can see there is a haze involving the both sides of the mediastinum, so it is less likely to be symmetric posterior mediastinal mass, and I
So
can see
if haze is not a finding of a posterior mediastinal mass, then what is?
this can be upper lobe fibrosis or pulmonary lesion,
Do you
pulmonary.
see changes of volume loss on either side?
No, sir, I can't.
So it can't be upper lobe fibrosis. What else can this be?
Consolidations. If
Do
the
you see
patient
air
has
program?
a
Do you think the whole process is in the lungs, or is it extrapulmonary?
uh, it looks to be in the lung apices, but lower neck or region can also be seen like this. But I want to see the
Let's take to the mediastinal widening. What are your differentials?
uh, the cause may be vascular, can be nodal, bony, pulmonary, and there is a lot.
When you describe a mediastinal mass, what are the important things that you look for?
First of all, I have to see if, patient know the patient history, and if the
On
acute
an
onset.
X-ray, what do you look for to decide if it is a mediastinal mass? And if it is a mediastinal mass, how do you differentiate it from an anterior mediastinal mass or a middle mediastinal mass or a posterior mediastinal mass?
Yes, I will look for first of all over in this case for cervicothoracic sign. If it is going above the clavicles, then it might be the neck lesion, and
Is it
in
going
the
above the
in
clavicles?
sorry.
Is any opacity going above the clavicles here?
No, sir, I don't can't see. I want
Okay,
to
what
and
else?
in the hilar or perihilar lesions, I will look for any hilar overlay sign if
Is
it is
there hilar overlay sign here?
and mm, left-sided vessels I can trace through this.
Okay, what else? All right, what else?
So if then the lesion can be interior or posterior. So, sir, I can see there is a linear dense area, can be calcification or dense spinous ligament. So I want to look for any ankylosing spondylitis, as there is some bilateral apical
You
fracture.
have the clinician standing with you. He wants your opinion on this case. Give me a diagnosis or an appropriate opinion that you think for this X-ray.
Sir, first I will
Just
inquire
conclude.
about.
I need few one sentence or maybe few words.
Sir, I will correlate history. If the physician is along with me, I can ask about the history.
The patient
Uh,
presented with fever. The patient presented with shortness of breath. Go ahead.
So, in case of fever and shortness of breath, I will uh, 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 conclude with the bilateral upper lobe, any consolidation or infective process.
What about the mediastinal widening?
That can be nodal in the case of like tuberculosis, sarcoidosis. Patient can have mediastinal widening due to enlarged lymph nodes.
What are you going to do next?
I want to do the CT scan with contrast on this patient. I am scrolling CT scan axial images with contrast from upper most part to the
I've shown you the lung window initially
yeah.
for you to evaluate if there is any consolidation and if there are pleural effusions.
Yes, I can see there is large multilobulated mass in the interior mediastinum. There is large left sided likely pleural effusion. I will see on mediastinal window. Uh, However, in the lung window, apart from few cystic changes and some ground glass minor uh, changes in both lungs, and this is also likely due to patient poor inspiration, as major airways are slightly narrowed. Uh, s- uh, so I want to see the mediastinal window. Uh, the mass is encasing the major thoracic vessels, encasing the SVC, causing its luminal nerving. However, contrast is easily passing through it, and no major collateral channel formation. So no currently no evidence of SVC obstruction. There is moderate left pleural effusion, and there is mild pericardial effusion. And there, and I want to see any pulmonary embolism. Uh, okay. There is no uh, pulmonary embolism in major vessels. So, on current findings, my differential diagnosis is of lymphoma. Further, I will do the staging CT scan, including neck and abdomen, pelvis with contrast. Then I will discuss
What do you know
patient.
about the staging of lymphoma?
Sir, we do the PET CT also, whole FDG PET CT.
Okay, can you tell me something about the staging of the lymphoma patient?
Uh, Sir, we do an Arbor classification system.
It is very old and our classification not used anymore.
Uh, yes. Other classification system is Lugano classification system, which is
Okay.
latest.
We finish here. Yeah,
Okay.
please stop scrolling. I'm
Yeah,
going to
thank you.
go back to the X-ray. I think this was very casually done, don't you think?
Yes.
Because when you talk about the media style widening, you really have to go into the depth of trying to figure out where in the mediastinum the lesion is located. All right. Your emphasis was not on the exact localization of the mediastinal lesion. Again, asking you one question here: is there any finding on this X-ray to suggest this is an anterior mediastinal mass and not a posterior mediastinal mass?
Yes.
You can see the descending thoracic
Uh,
aorta through the mass lesion.
yes.
Had it been in the anterior mediastinum, had it been in the posterior mediastinum, the descending thoracic aortic contours would have been lost. All right.
Yes.
Other than that, you were supposed to talk about this vicothoracic sign. You were supposed to talk about many other findings when you're evaluating for a mediastinal lesion. There was some blunting
Yeah.
of the left CP angle on this X-ray too. So overall, the case would be a pass for me. I don't know. But with the X-ray, it was a borderline fail because it was not very well described. The observation on the X-ray was not good. It was a borderline fail from my side. Clinical reasoning. Again, lymphoma patients can present with fever, can't they? Can lymphoma patients present
Yes.
with
They
fever?
can.
They can present with fever. But you should practice on the X-ray, especially the mediastinal lesions, because they are very, very important. When you see an X-ray in the exam, you have to evaluate the mediastinal lesion appropriately. All right. With your second case, with the second case, this cyst is called a peritoneal inclusion cyst. I wanted to hear the word. The cystic collection in the middle. You did talk about the surgical
Yeah.
changes. They're mostly associated with history of surgery. Can a peritoneal inclusion cyst be
Yes.
associated with the endometriomas?
Uh, yes. In the uh,
It can be. It
chronic
can also be.
long-standing cases, this can be.
Yes, it can be associated with endometriomas.
Yeah.
There was T2 shading sign which clearly indicated this is an endometriotic cyst. Can you appreciate the T2 shading sign here?
Yeah.
Can you see the
Yes.
fluid level with some slow signal in the posterior aspect of the cyst? So this was bilateral
Yes. These are.
endometriomas with the peritoneal inclusion cyst. Is there a malignant potential to peritoneal inclusion cyst?
Uh, Not for the cyst, but the endometriomas uh, can be a source of
So with the
can
knowledge
have
it was
malignant.
with the knowledge it was just pass. Observation was good since you were able to pick up on most of the things, so it was a pass on the observation. Clinical reasoning, safety management. With the communication, Dr. Saab, you need to work a little harder. You have to speak faster since I gave you a lot of time with both the cases, but in the exam you do not have a lot of time to be looking at
Yeah.
everything, taking your time. The time is running short. You're constantly on the run. You got to, and whenever a case is started, you first always comment on the positive findings. If in any case you cannot find a subtle finding, only then you start commenting on the secondary structures that I'm looking at this is normal, this is normal, this is normal. But when you see a positive striking finding, you immediately start commenting on it. And when you start commenting on it, a differential diagnosis or a diagnosis comes to your mind, and then you go and take the case accordingly. All right. So don't just go
Right.
haphazardly without sequence. When you see a pathology first, Stick to it. Take your time on that pathology. Stop wasting time on the other unimportant things for that particular moment. Do you understand me? Once you are done with the
Yes.
pathology, only then you start describing the other structures which are relevant, which are associated with the pathology that you're explaining. All right. So this was a pass on my side, but you need a lot of practice and you need to pace up. Yes.
Thank
So
you.
this was from my side. Thank you very much, Dr. Umair. Are you with us?
One more thing I want to add is that, mediastinal lesions are very important.
Mhm.
There will be one or two short case showing any of the mediastinal lesion. And this case, which Dr. Shahab showed, I was shown almost a 90% similar case in my Viva. Almost, it was almost a similar case. The CT was, I think, it was the identical copy. So please be aware that, they are going to mark you on the X-ray. They will not mark you on the CT. After they have shown you the CT, you have identified it anterior and posterior. They have marked you on the X-ray. So again, the plain film description is very, very important as far as these mediastinal lesions are concerned. Yes, the candidate he did very good on this case, and the other case again he was lacking a bit observation and knowledge. Otherwise, he just need to pace up a bit, do more practice, see more cases. Okay, so this patient has a motor vehicle accident, and he was presented to ER with shortness of breath, and they were suspecting pneumothorax. Okay.
Yes, this is a frontal chest radiograph of a patient who has presented with shortness of breath after motor vehicle accident. The endotracheal tube is in satisfactory position.
Mhm.
Um, there is a patch of airspace opacification in the right lung mid and lower zone, as well as in the left retrocardiac region. Um, There, mild to moderate fluid is noted in the left hemithorax, and there is mediastinal widening, which is noted on the left side around the aortic knuckle. Further, there is apical capping, which is noted on the left side. No pneumothorax is noted. Now I am looking for any fractures.
This is a supine projection. Just mentioned here.
Uh,
Okay.
yeah. No fracture is seen. And another pathology is a rounded opacity, which is noted in the right lung mid zone. And based on these findings, these appearances are suspicious for aortic injury, as there is widening of the along the aorta as well as left apical capping.
Mhm.
Further, the fluid in the left hemithorax is suspicious for hemothorax, which is mild
Mhm.
in volume, and the patchy opacities in the lung is suggestive of contusion and pulmonary hemorrhage.
So what will you do
I
next?
will urgently pick up the phone, and I also found a fracture. The
Okay.
fracture of the left first rib at the posterior aspect.
Okay.
I would urgently pick up the phone and inform these findings to the referring physician, and I would urgently raise the suspicion of aortic injury, and I will advise CT with the contrast in the aorta
Mhm.
phase for further evaluation.
Mhm. Okay. 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 So we move on to the next case. Good.
This is frontal chest radiograph of a female patient. Bilateral breast shadows are present, and overlying multiple wire artifacts are seen. These are likely the leads of the ECG leads, and there is a marked reticular opacities with some mild nodularity in the left whole lung. Further, there is an area of small area of airspace opacification in the left lung upper zone. The right lung is grossly unremarkable, and uh, there is slightly bulky hilum noted on the left side. However, this is partly obscured by the overlying lung parenchymal changes.
So, okay, conclude the
And
case, and what would you want to do next?
yeah. As there is no volume loss, so these findings are suspicious for lymphangitic carcinomatosis, and sarcoidosis is less likely as only one lung is involved. I would like to correlate with a history of any known malignancy, and I would compare it with prior imaging if available. I will inform these findings to the referring physician, and I would advise CT chest with contrast for further
Okay,
evaluation.
ask for the control. Ask for control, please.
Requested.
Okay. Wait, just wait. Okay. Okay. Start scrolling now.
Yes. This is a CT scan of the chest. I will first scroll through all images and then I will inform my findings. This is a soft tissue window and the scan is done with contrast.
Okay, let me show you the lung window, okay?
Yeah. So
Again, click on it just once and then start scrolling. Or yes, you can use this bar. Yes, I this thing use this bar. It will be easier in this case.
yeah. There there is nodular interstitial septal thickening, which is involving the left lung, and there are patchy areas of um consolidation noted. Sorry, this is a likely collapse as I cannot appreciate the air bronchograms.
Okay.
I would like to see the hilum further to see if there is any hilar mass. I would like to see the mediastinal window to see for any enlarged lymph nodes or any enhancing mass.
Okay, leave the mouse. I'll show you the mediastinal window, okay? Just
Yes,
leave the mouse. Thank you.
yes.
Okay.
Mm. There is enlarged left supraclavicular lymph node
Hmm.
here.
Okay.
Further, there is also enlarged right supraclavicular lymph node, and there is enlarged right paratracheal lymph node.
Okay.
There is enlarged subcarinal lymph node.
Okay, the mediastinal lymph nodes are enlarged, okay?
Yeah. And now I want to see if there is any bronchial mass on the left side. So no endobronchial mass is noted on the left side, and this is the area of likely consolidation, or yeah, or this
So
is
what
a
will you do
mass-like
next?
area of the
Okay.
mass-like area of collapse, which is noted here. In my routine practice, I would compare it with prior imaging if available, and these
Hmm.
findings are suggestive of diffuse lymphangitic carcinomatosis on the left side on background
Hmm.
of enlarged mediastinal lymph nodes,
Hmm.
and this can be secondary to primary. Uh, it can be secondary to any primary malignancy. I want to see the breast covered in these sections. There are multiple enlarged left axillary lymph nodes, yes. So multiple enlarged left axillary lymph nodes as well as enlarged left retropectoral lymph nodes, and I'm looking at the left breast now. So in the partly covered left breast, I can appreciate that there is some nodular opacity which I'm unable to completely see. And
Okay.
so my top differential is that the patient has left breast carcinoma with enlarged, asymmetrically enlarged left axillary lymph nodes as well as left
Uh,
retropectoral lymph nodes. I would also see the internal memory nodes.
So what what would you do
Uh,
next?
huh. I will pick up the phone and inform these findings to the referring physician. And further, if mammogram and ultrasound and biopsy of
Why
the
will you
breast
pick up the
mass,
phone? Why, what's the urgency to pick up the phone and inform the findings?
because there is lymphangitic carcinomatosis and it has really poor prognosis and it causes shortness of breath and patients are
So,
usually on
no,
oxygen.
is there something to be done urgently?
No, we do not do anything
No, so
urgently.
so you don't pick up the phone and yeah, just use these words when there is some urgency.
Yes,
Okay.
yes. Oh, yeah,
Otherwise,
yeah.
in routine practice, if you see lymphangitis, do you call the physician? No.
No.
Okay.
Yes, yes.
Okay.
So I would advise complete staging scan involving the
Okay.
abdomen and pelvis with
Yes, that
contrast
that 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 is
and
what I
bone
want to
scan
listen. Yes,
and
and
bone
one.
scan also
Yeah.
and biopsy of the breast mass and axillary lymph node if not
Yes.
already
Okay.
done
Okay. Good.
and
Good.
breast MDT discussion.
Yes. Okay. So, candidate four, I think you are brilliant. You are very good. You are very good with observation. I'll give you excellent in observation. Your observation is, it's way beyond excellent. Very good. But just try to conclude the case. You're just going on and on and to conclude the case, and also just move on to the save to the management part. Once you have done with it, move on to the management part. In this case, you correctly identified these unilateral reticulonodular shadowing, and and you mentioned all the points that there is unilaterality, there is no lung volume loss. What are the other causes of unilateral septal thickening or unilateral reticulonodular shadowing?
Tuberculosis
Yes,
can be
tuberculosis.
unilateral. Yeah.
Or mitral valve regurgitation can also cause the unilateral findings. And again, with the CT, you were again brilliant. You were very good. And you mentioned all the positive findings as well. And but just try to conclude the case. Don't linger on with it. Okay.
Yes.
And this was your first case. And again, I have marked excellent on observation and a clear pass in this case. Okay, so very good observation. Trauma. You missed this rib fracture first, but in your review you picked it up. And then there was a wheeling opacity. There was left apical pleural capping. There was mediastinal widening. And see, one thing you just I will not say missed. There is a deep sulcus sign. It's very difficult to appreciate, but there was a pneumothorax, but that's not the important thing. The important thing was to pick up this mediastinal winding, this pleural apical thickening, and this swelling opacity. So these such type of cases are very important in short cases as well, because it has got multiple findings, and also yeah, these such a similar case can also be shown in the Viva as well. But you were very good with the both of the cases. Okay, very good, and keep it up.
Thank you, sir.
Thank you, Dr. Mer, for very good cases. I think you covered it up. You summed it up very nicely. Candidate 4 is a very good candidate for the exam. She is doing really well for us. And just keep up the good work. Keep up your practice daily. Uh, this is for all. Those who do well, those who are unable to do well, you need to keep practicing till your exam. Thank you very much for today. Thank you all for joining us. Inshallah ta'ala, we'll see you guys next week for more cases.